Okay, I think we'll begin. I would like to welcome everyone to the first Dissemination and Implementation Science Workshop, a new workshop series headed by Bonnie Vest and Ranjit Singh, who are the director and the associate director of the D&I Core. And I think you're in for a treat today because you're going to hear about things that are very important to how we do things at the Clinical and Translational Science Institutes. And I really appreciate you all attending. I also wanted to tell you that we have other workshops within our series that are running this semester, especially the Responsible Conduct Research Workshop, which will actually be starting quite soon. And I'm going to put just a URL in the chat if you're interested, and please feel free to sign up for those as well. I also want to tell you that if you need to ask a question, please feel free to put it in the chat, and then I will ask at an appropriate time. Or if you have a question, go ahead and raise your hand. They are very openly willing to answer your questions. And now I'm going to turn it over to our wonderful presenters. Thank you.
Great. Thank you, Catherine. So I'm Bonnie Vest. I'm faculty in the Department of Family Medicine and the Associate Director of the Dissemination Implementation Science Core, along with Ranjit Singh, who, Ranjit, do you want to introduce yourself now, I guess?
Sure. I am the Director of the Primary Care Research Institute. I'm a family physician in the Department of Family Medicine here at UB, and work with Bonnie to lead this Dissemination Implementation Science Core.
All right. So we're very excited you're all with us. We're a brand new core within the CTSI, and this is our inaugural workshop series. So we're excited to be here with everyone today. Just to note that, okay. So today is the first workshops in the series, and then we'll have 3 more coming with the idea that the content will build on itself across the workshops. So the goal for today is really just to kind of dip our toes into dissemination and implementation science, think about what the primary goals are for D&I and how it fits into the translational science spectrum, and how we might start thinking about incorporating D&I into our studies, regardless of what place we fall along on that spectrum with our work. So to start off, we do just want to get an idea of who's here with us today and kind of where we're all starting from in terms of our knowledge and maybe any exposure to dissemination and implementation science. So we have a couple of poll questions, if you'll indulge us. So Catherine, if you can put the first poll up, please. So first, we just want to know, if you don't mind telling us how familiar you are already with dissemination and implementation science. Not at all familiar, a little familiar, somewhat familiar, or very familiar. And we'll give everyone a few minutes or a few seconds to answer. Okay. Looks like the responses have stopped. So, okay, so a little bit of a spread, but looks like mostly somewhere in the middle. So a little familiar to somewhat familiar with D&I. Okay, great. Okay, how about the next question? Okay, so our second question is, how would you rate your comfort level in applying D&I science to your research? Not at all, somewhat, moderately, or very comfortable. Okay, I think we can go ahead and close that one. Okay, so it looks like overwhelmingly the majority not at all to somewhat comfortable. Okay, that's great. So hopefully this won't be too introductory then for most of you, and you'll be able to take something away from these sessions, hopefully, that you can apply to your work. And then we just have one final question. Have you personally conducted or worked on a research study that incorporated D&I? And just yes or no. Okay, so we've got about a 60-40 split. Most people say no, and then about 40% saying yes. Okay, thank you all. That's very helpful. Just for us in kind of understanding where people are starting for this workshop, but also for future ones to understand how to target that information. So thank you. Okay, we can close the polls. And then just briefly, you can either put in the chat or if you're willing to share, we would like to just get an idea from you why you decided to attend this series, maybe what you're hoping to learn from these workshops. So if you'd like to speak, you're welcome to, or if you want to put it in the chat, that's fine also.
I'm a first-year PhD student in School of Nursing, interested in incorporating D&I into my learning and possibly dissertation. Another one says, I have been interested in the overlap between implementation science and human factors, as well as the potential to improve the real-world impact of my research. Next one, I do extensive basic social science research, and I have some familiarity with intervention research, but I know almost nothing here. And then two more, to see how I use implementation science in my own research. And finally, hoping to explore dissemination in future research and want to increase on this area. And actually, there's one more I'm going to add as well. I am transitioning to implementation science work and want to gain more training in this area.
Okay. Great. All right. So sounds like lots of interest in kind of learning how this work might apply to our two different kinds of research that folks are doing. So hopefully these sessions will help with that, and we'll talk through some examples that can help you see how you might apply these approaches to your own work. All right. Thank you all. And yeah, feel free to, keep putting things in the chat. We'll save it and review it later. And as Catherine said, if you have questions as we go, please let us know also. We're happy to answer them. So, okay, I'm going to turn it over to Ranjit now to get us officially started.
All right. Thanks, everyone, for being here. The purpose of this session today is to understand the answer to this question, right? What is implementation science and why should I care? Well, you obviously care enough to be here, so thanks for that. Our goal is to help you care even more, maybe by the end. Or maybe you'll learn that it's not for you. That's your choice. But at least you'll understand what it is. So let's go to, and this, but by the way, this is obviously, we're showing this because this is a good example of an article that answers that question. And there are lots of other resources online you can find, and there are videos you can watch and other articles that will help you gain an understanding of this, but hopefully we'll do that today as well. So let's just put now let's put implementation science in the context of the broader translational spectrum. So I don't know how many of you really have seen this diagram or studied it closely, but this is the diagram that NIH uses to describe what the overall functions are of research, translational research, which is the goal of the CTSA to promote. Starts with basic research on the right-hand side, slightly up. There's basic research. Thank you, Bonnie, for pointing that out. Yeah. Well, that's where all like scientific discoveries begin, in basic research, whether it's lab research or whether it's psychological research with or whatever it is. Doesn't matter what the topic is, but it starts with some understanding of mechanisms. So that's not translational, but everything that comes after that is translational, all the way around clockwise till you get to public health. And so the ultimate goal, of course, is to improve the health of the public, right? But to get there, we need to go through some steps. So there's preclinical research, which is, might be animal studies or studies with healthy volunteers who don't necessarily have a disease. And then there's clinical research, which is trying to now, at this point, when you get to clinical research, we have presumably identified a potential intervention that might work, whether it's a drug or a procedure or any other type of program or behavioral intervention, whatever it might be. We do clinical research to try to test if it actually works or not. And we start by testing it in ideal conditions, and then we progress through, and I'll talk more about that on the next slide. But eventually you get to implementation science at the very end, which is clinical implementation and then public health. So the idea is that once you can prove that something works by doing clinical research, you cannot just wait passively for it to be implemented. You have to actually take specific steps along the translational spectrum to get it to be implemented into the real world and then to improve public health. So that's basically what implementation science is about. It's about those upper two left-hand circles. So let's go into that in a little bit more detail on the next slide, which starts by explaining that, if you look at the quote on the left, that's a really important statement. Establishing that something is effective, like a drug or a or a program does not guarantee that it'll be taken up into routine practice. And of course, if it's not taken up into routine practice, then it's not going to benefit the patients that you're trying to benefit. Right? So this diagram we see here now has some similarity to the diagram we just saw. If you start at the bottom left, it talks about pre-intervention, which is like designing maybe a drug or an intervention that you want to try. And we go into efficacy, which is trying to demonstrate whether it works under ideal conditions. And a lot of times, a lot of people who are not implementation science type people, that's where your research ends, right? You want to show through by doing a traditional randomized controlled trial that your intervention actually works. But that generally looks at ideal conditions. So there's a step you can take next, which is getting you closer towards implementation science, which is to do something called an effectiveness study, which is, does it work in the real world? So that's sometimes called a pragmatic trial. This now moves the research into real world settings, which is where implementation has to happen. But it's not implementation science yet until you take this next step, which is to get into that box in the upper right-hand corner, where you start thinking not only about the intervention, but about how is it going to be implemented, what type of strategies might be used to implement it, and what type of context is it being implemented in. And so exploration might be looking at the context in which you're going to test your interventions. The next box up, moving up towards the right, is adaptation. Sometimes we might need to adapt the intervention to suit the context, or do some feasibility and piloting before we get into actually trying to implement it on a broader scale. Then we do implementation studies, but that's not enough. You have to be able to show that something can be sustained, because a lot of things fizzle out. And so when we see on the left that it says that it takes very many years often for things to get translated along this line, you can start to understand why it takes a long time, because there's a lot of research that needs to happen along that continuum in order to get to the point where actually your intervention is actually being used consistently. And I want to highlight now this statistic that less than 50% of proven effective interventions actually get to the point of sustainability where they're actually being part of routine practice. That's concerning, right? Well, the next slide talks about that a little bit more. So why is it that some interventions don't actually end up being sustained in practice? It may be that they just proved to be not as effective as we thought they were, right? But there's another problem that implementation science tries to handle, which is that sometimes things don't end up sticking in the real world, not because they're bad, but simply because we fail to translate them into the real world, right? It's more of an implementation problem than actually a problem with the intervention itself. So that second bullet is asking that question. Is this an intervention failure or a failure of implementation? So there's an example of the diabetes prevention program, for example, that was proven to be very effective in ideal conditions, in efficacy studies, right, in clinical trials. But when it was attempted to be translated into the real world, things didn't always work out so well. Maybe that was a failure to adapt it to the context. Or maybe the strategies that we used to implement it were unsuccessful. It wasn't necessarily a problem with the program itself. It was more a problem with the intervention. So the idea of implementation science, what implementation science can do is to help us tease out the difference, right? And make sure that interventions that are effective actually can get implemented instead of being abandoned. And that very last part of that last bullet makes a really important point. One of the keys to getting successful implementation so that something sticks and doesn't get abandoned is to adapt it to the context, right? So understanding those contextual factors and designing an implementation plan that deals with those contextual factors can be critical to making sure something sticks in the real world. So let's go to the next slide. This is, I think, saying the same thing, that, right? We sometimes we leave things on the shelf because we fail to adequately figure out how to implement them. And the purpose of implementation science is to really avoid that problem, right? Bridge that gap, mitigate that problem. So let's go to the next one. I think this is Bonnie's turn.
Yes. Okay. So what is dissemination and implementation science then? And so the definition from this paper, they define it as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practice, and thereby improve the quality and effectiveness of health services. So that's a bit of a mouthful, but we're really looking at how, what's the process and the outcomes of implementation in the real world, and how do we, act as that bridge between the intervention and its adaptation and adoption. And so, in other words, I think this is a slide from Jeffrey Curran, who's a leader in the field of implementation science, and he developed this slide specifically for these purposes to be used as a teaching tool, and says that when defining implementation science, we're going to use some somewhat non-scientific language. But if you think about the intervention or the treatment or the practice as the thing, right? As Ranjit mentioned, effectiveness research is looking at whether this thing works. Implementation research is looking at how do we help people do this thing, and how we help people do these things are using implementation strategies. So we use these strategies to help people do this thing, and instead of measuring whether the thing works, we are measuring implementation outcomes, which are how much and how well are people doing this thing. So are they actually taking it up into practice? And so really the crux of implementation science is to identify barriers and facilitators to uptake across multiple different levels of context. So it could be the individual patient level, it could be at the provider level, it could be at the system or the organizational level, as well as in the community. So looking at all these different levels of context, all these different factors, can we use scientific approaches to identify the barriers and facilitators that are impeding that successful implementation? And then can we apply implementation strategies to help address these barriers, to help enhance the facilitators so that we do ultimately increase that uptake of those innovations and come to a successful implementation? And so really, these are our two main activities within implementation science, to address these contextual factors and then figure out what strategies will help us be most successful in that implementation. So Ranjit, we'll turn it back to you.
Okay, thanks, Bonnie. So in implementation science, let's look at the bullets on the left first. So because now you've heard from Bonnie that goals are different than a traditional randomized controlled trial, for example, we have to employ different types of study designs because we're asking different research questions and therefore have different types of hypotheses. We pay a lot more attention to the context, and therefore we're also looking at different outcomes. As Bonnie mentioned, that focus of the outcomes is not on did the thing work, but it's on how did it work? And we're going to talk a lot about outcomes for the rest of this presentation as well. But so just to look at this table for a second, just to highlight the difference. So on the left, we have efficacy of traditional randomized controls trials that are highly controlled, strictly defined inclusion, exclusion criteria. The outcomes tend to be at the patient level. They tend to be clinical outcomes. Patient is the unit of analysis. On the other hand, implementation studies are in the real world. So let's look at the upper right-hand cell there. And therefore, there's a lot of compromises we have to make in order to go into the real world, right? You can't control everything in the real world, right? And if you have too strict inclusion and exclusion criteria, then things don't work very well either, because now you end up narrowing down the population to an unrealistic group. And if you're going to try to implement things in the real world, you need to have simple inclusion criteria like diabetes, right? Or diabetes with some caveats, but you can't exclude all kinds of other comorbidities, for example, because then it becomes not really implementable in the real world. So having a real world context is really critical to implementation studies. And oftentimes the unit of analysis is not the individual patient. It could be a clinic or a health system or a hospital, whatever it is, because typically when you implement a new practice into a setting, you have to train the doctors in the new program or whoever is implementing it, whether it's social workers or counselors or whoever, depending what the program is, right? And so you can't, in real-world implementation studies, expect to be able to randomize patients. It makes more sense to randomize at the practice level. And we'll talk more in workshop number 3 about how you might do research designs that involve cluster randomization, for example. So that's a big difference in the basic design. And then, as was mentioned before, the hypotheses for efficacy studies are more about, does the thing work, maybe compared to a control, whereas in implementation studies, it's more about the strategy to get people to implement it. Does the strategy work? Can we compare different strategies? The outcomes are more about the process and less about the clinical outcomes in implementation studies. And we're going to talk more about that. As I said, we're going to pay much more attention to the context. So instead of in an efficacy study where it's really about trying to eliminate any effect of the context, right? You try to control for that as much as possible. In implementation studies, we really grapple with the context. We want to understand the context. We even want to adjust the intervention to fit the context. So that's a very different way of thinking about context. Instead of thinking about context as these annoying, confounding factors that we have to somehow tolerate or try to control for, we engage actively with understanding the context because that's the real world reality. And then the similar thing with fidelity. So in an efficacy studies, you really pay a lot of attention to, is it being implemented as intended? Well, in implementation studies, because we're in the real world, we have to monitor the fidelity, but we also have to realize that people will adapt things as they're going along. And sometimes that's planned, sometimes that's unplanned. And we have to face the reality that people will do that. And so try to monitor it and understand its effects, understand why they adapted and changed things so we can learn for the future, and understand whether the adaptations they make are actually at the periphery, which may not have any, it may still be effective even if you make those adaptations from the outside, or if they make fundamental changes to the intervention, it may compromise its ability to actually work. So we have to grapple with all of those things instead of just trying to eliminate them. And so this is showing two extremes. On the one hand, we have efficacy studies. On the other hand, we have implementation studies. In between, there are other types of studies, which we call hybrid designs, which we'll talk more about again in workshop number 3, where you are looking at both, right? So those are actually the most common, but this is just to illustrate and contrast the different goals. So let's go back to the question of outcomes and talk more about what we call this process outcomes. So in implementation science, there are a lot of different ways about thinking about outcomes. And as I mentioned, you might also be looking at clinical outcomes, especially if you're doing a hybrid study. But this is just to list the strictly implementation outcomes that we try to think about. And there are lots of ways of categorizing these. And in workshop number 2, where we talk about theories, models, and frameworks, there are we'll see that there are other frameworks to describe outcomes of implementation. But this is probably one of the most fundamental ones that came from Enola Proctor, who's really one of the pioneers in implementation science. And you see the list of these items here. Each word is kind of self-explanatory, but there's a little explanation after each one to try to flesh it out a bit more. And you can see there's overlap and they're not all mutually exclusive, but you'll notice that they concentrate on things that are beyond just, did the patient get better, but can we actually do this intervention in the real world? That's what feasibility is about. Can we actually fit this intervention into routine practice, right? That's a fundamental concept in implementation science, right? So that's why that's important. Acceptability is closely related, right? Are the people who you're asking to implement this actually going to view this as something that they're willing to do, whether it's the patient or whether it's the person delivering the care? Adoption is more about rates of adoption, of how many people are actually using it. Appropriateness is, related to acceptability, right? It's like, how do people perceive whether it's actually appropriate to do this, and how does it fit with the alternative treatments that might be available, et cetera, et cetera. Fidelity, I already talked about, that maybe we do pay attention to fidelity, but we also have to think about adaptations as the flip side of that. Penetration has more to do with within an organization, for example. Maybe you could say that this hospital adopted this intervention, but it may not be uniform within that entity. So there may be, in some organizations, it may be only a few people who are champions who use this new intervention, but in others, it might be spread deep into the institution. It becomes institutionalized and the normal practice. So that's another concept. Cost, I think, is self-explanatory. Sustainability is critical, right? And that was why that was the holy grail at the end of that pathway on that earlier diagram where we had that progression from the bottom left to the top right. You can't say it's got into routine practice until we achieve this sustainability concept too. So these are all critical things that we need to understand. Now, in any given implementation study, depending where you're at in terms of the science, you may be picking and choosing individual items from this list, right? So the ones at the top are more for early stage work, or the ones at the bottom are obviously more, the ultimate goal is to do something that's cost effective and sustained. So you don't have to feel that in every implementation study, you have to measure all of these things, but this is a framework to provide some guidance of the types of things that you need to measure to inform whether or not things are being implemented as intended or implemented at all, and to inform how you might design intervention strategies to improve that uptake the next time around, right? So these are the critical concepts in terms of implementation outcomes, which we'll come back we'll come back to this more later when we get into the small group discussions where we'll have you think about these more. So let's go to the next slide. All right. So let's take a step back and ask ourselves, okay, if you remember that circle that started, or that even that slope, whichever one you prefer to think about it, where we think about the progression from clinical work into implementation work, or even if we go further back into more basic bench research, it's important to note that implementation science, or the thought process around implementation, can be incorporated wherever you are in the translational spectrum. So even if you're doing, for example, a traditional clinical randomized controlled trial where the goal is just to see if this thing works or not, is this drug better than the other drug? There's an opportunity to think about what are some of the implementation issues that might come up. If it does prove to be effective, what might be some barriers to its use? And so now if you start looking at process type information while doing a randomized controlled trial, now you, technically speaking, you're getting more into a hybrid type of design. But even if you don't incorporate that in the actual study, you should at least be thinking about it, right? For example, you don't want to design a program or even a drug that has to, a drug, for example, that has to be administered in a way that people probably wouldn't be willing to do, or a program that's so complex that nobody's going to do it, then you probably should think twice about really investing millions of dollars in doing multiple randomized controlled trials on it, if it's something that's going to really prove difficult to scale up. So the logic here is that thinking about implementation science or implementation issues should be something that should be in the process right from the beginning. And you could argue even from the very beginning, even if you're doing bench research, you should be thinking about what's the next step? Where is this going? And if you're forward thinking enough, you can think about, okay, is this bench research potentially, can it lead to something that could eventually help patients, right? So if you remember that circle that I showed you from the NIH website at the very beginning, it's not presented as actually a circle around clockers, which is how I talked about it. I was remiss in mentioning that there's arrows between all of those, right? So that those arrows are supposed to remind us that we should be thinking about all of these things almost simultaneously. And from an implementation science perspective, that really means there's the opportunity to think about implementability right from the beginning. So I'll stop there on this slide. And I think we go now to Bonnie.
Any questions that have come in at all, Catherine?
No questions at this
Okay. All right, great. So as you can probably tell from this discussion, doing implementation work and implementation studies requires a lot of different types of knowledge and expertise. And so studies are often very multi and interdisciplinary, and you need people with lots of different skills at the table. And so I'm going to just talk through an example of an implementation study that I was a part of many years ago, just to point out some of the, put a little concreteness to some of the concepts we've been talking about and point out some of those features. So this was a study it was a large trial funded by NIH, about 13 years ago now, looking at translating evidence-based guidelines for chronic kidney disease management into primary care. So there were these evidence-based guidelines. These are all of the guidelines providers should follow, taking care of patients with kidney disease. But we know that not all of those guidelines were being followed. And so the goal of this study was really, how do we increase uptake and guideline concordant care for chronic kidney disease? And so the study team for this project was huge. It included myself and Linda Kahn, who were both medical anthropologists. We have expertise in qualitative methodologies. And then, there were primary care providers, there was a nephrologist. So we had that specialist kidney care, a whole range of folks involved in this study to help understand all of these different moving parts. And so this was actually just a hybrid trial, but further towards the implementation end of the spectrum. And so just some characteristics of this study. So randomization occurred at the clinic level. So an entire practice was randomized to either the intervention arm or the control arm. And everyone within the practice then received the same support, all of the providers. All of the practices across both arms received some computer decision support tools that were embedded into their electronic health records to prompt providers around some of these guidelines. And then they all received an initial academic detailing session from the nephrologist and the primary care provider, reviewing those guidelines and kind of talking about the care. Then within the randomization, the practices that were assigned to the intervention arm received practice facilitation. So these were individuals who were assigned to that practice to work with them over the course of the study on workflows within the practice, process, modifications, had monthly meetings with the practice staff and leadership to talk about challenges they were experiencing and help come up with solutions to those challenges. And so the outcome in this study was not the patient outcome of looking at their chronic kidney disease, but it was looking at adherence to this guideline concordant care. So it was really a practice level measure of how many patients within the practice are receiving guideline concordant care, with the assumption underlying that would then lead to better outcomes for the patients. And so the hypothesis was that these intervention practices that had this extra support, these practice facilitators to work with them on all these issues, would have better adherence to the guidelines than the comparator practices who just had the initial session and the computer decision support. Patient outcomes were measured, but that was a secondary outcome of the trial where they were looking at chronic kidney disease progression, but that really was not the primary goal. The study was powered and the analysis was focused around this adherence to the guideline concordant care. And then within all of that, while that's all going on, we had an embedded process evaluation, which is where I came in as the qualitative person along with Linda Kahn, who led that piece, to look at what actually was happening in the practices. And so we used an implementation theory called normalization process theory, which we'll talk a little bit more about in the second workshop, the different theories and frameworks that we use in implementation science. And we did qualitative and mixed methods work to try to identify implementation outcomes and the barriers and facilitators to using these guidelines. So, there are all sorts of reasons why a provider may or may not follow a particular evidence-based recommendation. It might be patient preference. It might be the insurance doesn't cover this, even though the guidelines say that that's what should be happening. It could be that in our practice, we just don't have the support available to follow this recommendation. So there could be a whole range of different things that are going on. And so the goal of that qualitative work was really to understand what some of those things were and how did the providers feel about this? Did they feel these guidelines were feasible and realistic for their patients in their setting? And so we did interviews with the primary care providers who were participating in the project. We also reviewed notes from all of the meetings the intervention practices had with their practice facilitators and their emails. So we were using all this qualitative data to kind of understand the full picture of what the facilitators were working on with the practices, what that process looked like, what challenges were coming up, what solutions were coming up, and how did the providers see all of this fitting into their daily work with their patients. So that's just a brief example of an implementation study. And as you can see, it was very inter and multidisciplinary. Almost every implementation study I've been a part of, we used mixed methods. So we're combining both quantitative and qualitative sources of data and information, partly because as Ranjit mentioned, the context is so complicated and messy, right? And multifactorial that you really kind of need those qualitative methods a lot of times to understand how all those pieces are coming together. It's hard to measure sometimes with other approaches. And we're also looking at process a lot, which qualitative data is very suited to look at process. And then we're also engaging with the stakeholders and the community, whatever that might mean for that particular study. But those groups are often at the table when we're doing implementation work and trying to understand their perspectives and what they see as the challenges and what they need to support that work. So with that said, we are going to allow you all the opportunity now to start thinking about some of this yourself. Do we have a question? I just saw a chat pop up. Is there a question before we switch to that?
Nope, they just need some information for the next activity.
Okay, perfect. All right. So Ranjit, do you want to introduce our interactive activity?
Thank you. Hopefully this is the fun part for everybody. You don't have to listen to us anymore. You're going to be in groups of probably 6 to 8 people, right? I think we're going to break you out. I think you're going to be assigned automatically to a group. So you need to start by introducing yourselves. I think these type of activities sometimes can lead to, who knows, collaborations that can last a lifetime. So take those opportunities to get to know who the other people are. But that's the limited time. We suggest you do just a very brief introduction of who you are. And then hopefully there's one person in the group who can talk a little bit about a project that they're working on. And you have to pick one for group discussion, ideally, right? So have somebody volunteer to say, yes, I'm working on a project where maybe we could discuss here. And pick someone to be the reporter so that when we call on the groups, someone will be ready to speak. But the activity for the discussion here is thinking about that project that somebody brought up. From an implementation science perspective, think about what are the implementation outcomes that would be relevant to this project. Now, it probably will be the case that in this project that you have in mind, you are going to be looking at clinical outcomes as well. But for the purpose of this discussion here, we want you to think about the implementation outcomes from that checklist I went over with you earlier. So in the chat, you'll see, I think there's text repeating these instructions that I just went over, but there's also, more importantly, a copy of that slide. So if someone could pull up that slide within your group and just read down the checklist maybe and think about, so you can as a group talk about, okay, if we want to assess feasibility, could we do that? Would that be a goal to assess feasibility? And if so, what kind of things could we measure? And again, those might be quantitative things you can measure, or they might be things you want to assess qualitatively. And you could run down the list. You could start from the top of the list or the bottom of the list or the middle of the list, wherever you wish. And your choice, as I mentioned earlier, might depend on the type of project and the goals of the project. So whoever's project it is, maybe start by having them talk a little bit about the project and what they're trying to accomplish. And then as a group, try to brainstorm some things you might measure. So, Bonnie, is there anything else we should say by way of preparation?
No, I don't think so. Yeah, and we'll have about 10 minutes or so in the breakout room. So just, don't take up that whole time with your introductions. We want you to have some opportunity to discuss this as it relates to a specific study so you can start thinking like an implementation scientist. And then we'll come back together and share and talk about any other questions.
Great. I'm going to open the room Zoom.
Thank you.
Okay, so I'm not going to put the slides back on just yet because that way we can see each other, but we would like to have a little bit of discussion about maybe some of the things you talked about. So if someone from each group would be willing to report out, we just would like to know in like 1 or 2 sentences what the project idea was that you spoke about and one outcome that you discussed in your group and how you might measure it. We do want to mention this portion is being recorded still. So if there's something you don't want shared or part of the recording, just please let us know before we do that. But we'll just pick at random. Would anyone like to volunteer to go first from any group? Carl, I see a hand first. Go ahead.
Yeah, we had some discussion about a project I'm interested in, and that would be implementing new law that in New York's hospitals that would allow them to dispense a 72-hour supply of methadone for the purpose of bridging to an opioid treatment program, something that the federal law has changed just recently. New York state law has aligned with that. It's more than 2 sentences. Sorry about that, but
No.
I think the outcome is acceptability at this point. It's going to take some time for people to. This is 180 degrees from what folks are used to.
Mm-hmm. And did you talk at all about how you might measure acceptability around that topic?
No, we didn't really get that far.
Okay. Nope, that's okay. No problem. Great.
Does anyone have any ideas now about how they could do it? Can we help Carl out?
Well, there's another outcome, penetration, in terms of how many of New York's hospitals will actually take the initiative to develop policy workflows to do this.
Mm-hmm.
So, and that's a percentage. That would be a.
I mean, I had, if anyone else wants to say, please chime in, but I had a thought about acceptability, which is there's a question of acceptability to whom, right? I mean, there might be acceptability to the hospital, acceptability to the providers who are doing the prescribing, acceptability to the patients even, or acceptability to other stakeholders that might be of interest. And I think that might be the first question to think about with acceptability is acceptability to whom. And then depending on who the audience is, maybe acceptability can be measured in some quantitative ways, but sometimes it might be better, as Bonnie would say, to get a richer understanding of it by doing some qualitative stuff. So, but yeah, that's a really interesting example. Yeah. Thank you for sharing that.
Sure.
Great. Thank you. Anyone else like to volunteer what they spoke about?
I would be happy to share.
Sure.
So my group discussed a medication summary sheet to be given to patients along with their discharge information when being discharged from the hospital, particularly for geriatric patients. It's a project Ranjit is on as well. And we talked about quite a few different potential measures, but I would say the biggest ones that we discussed were feasibility, how it could actually be built into the EHR and then utilized by nurses, adoption as far as whether or not nurses and patients were kind of utilizing it for conversations and information search around medication use, and then sustainability of whether that's something that like patients could continue to access and continue to use once they've made the journey home.
Great. Thanks. Do we have anyone from our next group? I don't know which groups have already gone, so I can't call on you by number. That's my
I
bad.
can go ahead next.
Okay, great, Mo.
Hi, Bonnie. So our group discussed a mobile health intervention specifically for providers and patients, specifically pediatric patients with obesity. And one of the we discussed adoption specifically in terms of the providers and the patients. So measuring that for providers could be interviews, focus groups, things like that. And then in terms of the patients, one of the things was the parents obviously are going to have to be involved. So maybe getting questionnaires for them as well, and the usefulness and time and things like that in terms of adoption.
I guess I can go next. We talked about my potential dissertation project. I'm interested in increasing vaccination rates among pregnant women. What I found in the literature is that they are concerned about vaccine safety and fetal development and all of that due to misinformation, lack of trust in the healthcare. provider, the government, pharmaceutical industry, et cetera. So I'm not sure that we got to talk about outcomes, but we did talk about me needing to identify the sources of information, where they're getting their source of information, and the best environment where I could deliver a potential digital intervention, because I'm interested in communication. And I know this is way more than 2 sentences, but this is where we kind of finished, that I received some suggestions from the team members.
Yeah.
Oh,
Great.
great to hear that you had some good discussion. And does anyone have any suggestions, or do you have any thoughts now about outcomes? Not to put you on the spot, but anyone from the group want to talk about things you could measure?
The outcome that I'm trying to measure is vaccine confidence, because I think increasing vaccine confidence is going to improve vaccine uptake in that group. So I'm thinking of, I definitely want to do an intervention study, because I think there's already been a lot of research on vaccine hesitancy, and I don't want to focus on that. I want to focus on ways where we can improve their confidence in vaccine.
And so, like any concept, I mean, maybe it's important for us to try to find if there's already a validated instrument for that, right? Because we're not getting into this much today, but we talked about a few different things we could measure today. But there's always a challenge of, well, asking a survey question might measure the thing you're trying to measure, but it not necessarily, right? So I just wanted to mention that when we talk about some of these concepts, it's important to search the literature to figure out, has anyone developed a validated instrument to measure that construct or not? Or if not, then that might be the work that you need to start with, right? It is, if you've hit on a concept that's really important as an implementation outcome, if there's no validated way to measure it, then we may need to figure that out first before you can actually try to measure.
Yes, thank you.
Yeah.
I did find one, the NVAX. Don't ask me what that stands for, but NVAX, vaccine confidence. But I think I need to tweak it. But yeah, thank you.
Yeah, and thinking about like implementation specific outcomes you could sort of measure along the way too. If you're thinking about doing this as a digital intervention, like you said, there might be some things to think about around feasibility, acceptability, who's your audience? Are they open to a digital message, or would they, prefer in-person communication from a trusted source? So there's those kinds of things that you could think about in terms of, what's acceptable to the group you're trying to reach, and what's feasible. If this is coming from like the doctor's office, or if they're getting this information other ways, just thinking about some of those sort of process pieces. Those would be sort of the implementation components that you might start thinking about as well, that you could explore along the way. Yeah. Any other groups that would like to share a little bit about what they spoke about?
I can go. So I work with Jennifer Reed in the psychology department. I'm in the School of Nursing, and we developed an intervention to reduce alcohol-involved sexual assault among college women that we're currently trying to adapt for use with a military population. And it's it's grounded in motivational interviewing and bystander intervention, and it's delivered to dyads of close friends that go out drinking together, where these things might happen. So in addition to doing some pilot studies of the efficacy of it, we've been doing some qualitative interviews where we're talking with sailors about, asking questions like, how feasible is this? How is this stuff relevant to military? Do you care about this? Is anybody interested in changing these behaviors and those types of things? So, so far that's mostly been qualitative. And then we also have another level where we're going to be talking to like a military advisory board to, again, see like the feasibility of implementing this through like a base or something like that.
Mm-hmm. Yeah. Yeah. That's another one where you might think about like the penetration, right? And how far does this, what's the uptake, even if it's acceptable to the individuals, right? Does the organization see it as valuable and uptake as well? So, yeah.
Right.
That's great. Well, I mean, I think that covers most of I'm going to put my slides back up so we can finish our discussion. All right. So we did our report out. So, we just want to mention, as we said, this is the first in our workshop series. We will be doing the next one will be in 2 weeks from today, same time, same place, on models, theories, and frameworks, which are one of the primary topics within implementation science, because as you can probably tell from these conversations and the examples we talked about, there are so many moving parts and different pieces to consider and measure that we often are using some conceptual models and frameworks to help organize all of that and guide our work. So we will dive into that in much more detail in the second workshop. Then the third one, we'll get into the more about the study design components that we touched on a little bit today, but thinking about different types of study designs that occur within implementation science. And then the final one is thinking about all of these kind of contextual factors, and how do we identify them, and then how do we thoughtfully choose strategies to help address those factors. I do also want to mention, if you really want to go further into this, there is a course that's being offered for the first time in the School of Public Health on an introduction to implementation science, a full semester long course that Dr. Adu Frimpong is teaching. So, if you want more really want to dive into this, that's available as well, newly available through the university. Does anyone have any other questions or thoughts for us? Anything else you want to discuss today?
We do need feedback, I should say. So please
Yes.
be generous in your feedback. When I say generous, I don't mean be nice to us. I mean be plentiful. Be plentiful in your feedback, good or bad. We want to know how to help certain needs as best as we can. So please tell us what we should do differently next time.
And one way you can give feedback is I put a link to the survey in the chat a couple of times, and I'll also be sending it out tomorrow and probably towards the end of the week as well. So please feel free to do that, because they will get the feedback. So if you don't do it here, please feel free to give the feedback there. Thank you. You're having a lot of really nice comments. Good start. This was great. Thank you. We have some hearts. So good feedback. Thanks. Also, if you want CE credit, there is a document in the chat. Please feel free to upload that, and that's specifically for pharmacists. And if you are a physician, you will get CME credit for this, and that is given after all of the presentations have been presented. So you'll get that as well. Thank you.
All right. Well, happy Valentine's Day to everybody.
Thank you.
Thanks for
All right. Thank you, everyone. We hope to see you again.